I drew kind of the short straw, so to speak, for topic today. I really like to talk about moving forward with new therapies and new developments in finding a cure for CF. But the reality is that we still do need to face lung transplant for many of our adult patients and some pediatric patients in 2008. So I'm going to try to put a little bit of meat on the bones here in this talk. There's a fair amount of technical detail. Don't worry about trying to get it all during today's talk. We have this is all being filmed, so you can review it on DVD later, and also you have a handout. And I should mention in the handout that the order is not exactly the way it is in the slides, so you may have to jump around a little bit. The first slide shows us an explanted lung from somebody who went through lung transplant. You can see that the hallmarks of cystic fibrosis are quite evident here on the gross pathology. You can see these large cystic areas which tend to accumulate mucus. And the middle view here is a computer-generated cartoon of what the beautiful branching pattern is in a normal lung, where we have this beautiful arborization of branching airways and blood vessels that we hope to restore with the transplant process. And this is a young lady who went through a lung transplant, a lady with cystic fibrosis, not from our center, but I thought it was a nice photo showing somebody who's gone through the process and has gotten back to a relatively normal lifestyle. So it all starts with salt and water. And for those of you who've been at Maine Medical Center, I've given a lot of talks on ion transport. That's what my basic research interest was when I was working in the lab at the University of Pennsylvania. And we know that one of the fundamental defects that occurs in the lungs of patients with CF is that there's an abnormality in salt and water transport in a very thin lining layer in the lung called the epithelium. Those airway epithelial cells are very important for clearing mucus out of the lungs and for maintaining patency so that air and gas exchange can happen in the little air sacs called the alveoli. So in all of us is a very fine balance for our human salt shakers, and in CF that balance is thrown out of whack, and the downstream effects are that we get plugs of mucus in the airway that tend to be a nice environment for pathogenic bacteria to grow. What we're working on a lot nowadays is trying to restore normalcy in this area here, which is the battleground in the airway. And Tim is going to be talking next about some of the really promising new therapies that we hope to offer. But when we aren't able to accomplish normal physiology in the airway, there's eventual inflammation, scarring, and destruction of the lung. And what we're left with is a lung that, even with the best therapies, can't really be restored to normalcy. And that's where lung transplant has a role. So during this talk, I'm going to run through a number of different areas. I'm going to give you a little bit of history. It's really a very interesting history of how lung transplant was developed for humans. I'm going to talk to you a little bit about how transplant is done, kind of the plumbing of it and why it works in patients with CF. I'm going to go over some of the national statistics, and if you're interested, there are websites where you can pore over this in more detail, so I'll give you some of the web addresses for that. And then from a personal standpoint, if you're a patient who's beginning to consider lung transplant, what are some of the questions that you want to go over in your own mind as you begin your planning? How do we all go about picking the appropriate transplant center for you? And then I'm going to talk a little bit about the listing process and finish up with a little pitch for our own center, our role in this whole process, how we follow you through, and some of the local resources that we have available. So to start off with, I have to insert a little bit of religion. Developing the lung, creating the lung, is easy for some people, but it's not easy for the rest of us. This is a Far Side comic showing God up in heaven, making little snakes, and he's saying, boy, these things are a cinch. So if we had God's capabilities, making a new set of lungs would be a piece of cake, but we're not in that position. So we actually have to get a donated lung from somebody else to restore normalcy in the CF patient. Now, the first single lung transplant was performed way back in the 1960s, before the advent of some of the important medications that we now have in our armamentarium. And as expected, the lung didn't last very long. These lungs were rejected rather rapidly. And over the next 20 years, almost 40 single lung transplants were performed worldwide without real success. In 1981, the first heart-lung transplant was performed in Stanford, not for cystic fibrosis, but for somebody with a condition called pulmonary hypertension. And at that time, there was a medication available called cyclosporin that allowed durable function of the transplanted organ. Now, following that, there was experimentation as to the appropriate approach to transplanting the human lung. There were certain groups that felt strongly that you needed to transplant both the lung and its biggest supplier of blood, the heart. And there were other groups that were beginning to experiment with just transplanting the lung itself, leaving the host's heart intact. And all of these efforts were greatly enhanced by use of potent immunosuppressive medications, the major one being cyclosporin, but prednisone is another one that's frequently used. Next. So for cystic fibrosis, the first lung transplant was done. It was at the University of Pittsburgh, which continues to be one of the major transplant centers in the country. This was done in 1984, and it was quite a bold and courageous move, because at that time, we didn't even really know what caused cystic fibrosis. And that patient lived for a period of time, but died 6 weeks post-operatively from a viral infection, which is still one of the challenges that we face today. Now, in Europe, in parallel, there were teams that were looking at lung transplant, and their approach was a little bit different. They believed strongly that it was a more successful procedure to transplant both the heart and the lungs. Now, many of you may not realize, but CF patients have a lot of problems, but one problem they don't have is problems with their heart. They have vigorous hearts that would be would be very much desired by many patients who have atherosclerotic heart disease. So it seems a bit of a waste to take a heart out of somebody with cystic fibrosis and not use it for something. So in England, what they ended up doing was something called the domino procedure, where they would do a heart-lung transplant, but then take the CF patient's heart and donate it to somebody else. I put this slide in just to remind me to talk to you about how challenging it must have been for those first doctors to do a transplant in somebody with cystic fibrosis, not knowing what caused the disease. There were certain camps that thought that CF was actually caused by something that circulated in the blood. So if you could imagine transplanting a lung into a person that would then redevelop cystic fibrosis in the new lungs, you can imagine how much static they must have heard. But as it turns out, the battleground in CF is, as I pointed out in one of the earlier slides, is that very thin layer of cells called the epithelium in the lung. And those cells are repopulated by the stem cells within the donor lung. So in one sense, lung transplantation is a form of gene therapy. We haven't heard too much about gene therapy recently, but lung transplant is in fact a form of gene therapy where there are cells that have normal cystic fibrosis genes in them, and they repopulate that epithelium with cells that have normal cystic fibrosis genes. This is just a picture. I think you're going to see this one again in a later talk, but I think it's a beautiful one. It shows the delicate nature of these respiratory epithelial cells. In the proximal airway, we have these long, slender cells. These are the nuclei that are stained blue. These long, slender cells have these carpet brush elaborations called cilia that work really to move mucus and fluid from the distal airway up into the proximal airway. And if you don't have this whole apparatus working properly, if you don't have just the right amount of fluid and salt on the top, everything gets stuck. So thankfully, in the transplanted lung, these cells are replenished, just like the cells on our skin. You couldn't get by if you just had skin put on you and it couldn't replenish itself. It would just slop off and you wouldn't have anything left. The lung has regenerative properties. So where does CF fit in the world of transplant? This is from the National Registry, and this is available online. It looks at, by primary diagnosis, the patients who are on the active lung transplant waiting list. And shown right here are patients with cystic fibrosis. So you can see that about 20% or so of patients on the waiting list at any given time have cystic fibrosis, along with more common diseases like emphysema, chronic bronchitis, and some rarer diseases like, for instance, idiopathic pulmonary fibrosis. I'm just going to spend a few moments going over the plumbing. We won't dwell on this, but just so that you know that there are different approaches to this, and that there's probably been a degree of evolution with most centers now focusing primarily on this technique, which is the bilateral sequential lung transplant. So the heart is left in place. In these upper two, we either have a bilateral lung transplant where the two lungs are taken out as a single unit and then transplanted into the recipient, or in this case, you have a heart-lung transplant. The advantage to doing bilateral sequential lung transplant is it's a little less complex than having to remove the heart. You also have a little bit better blood supply to the bronchi, which are the main air tubes that go to each lung. And finally, it allows the surgeon to have one lung working at a time, so it's a little bit smoother procedure, and it allows them sometimes to get away with doing this without putting somebody on bypass, heart bypass machine. So again, just to review, and this will be in your handout and on the DVD. So again, I'm not going to dwell on it, but with heart-lung transplant, it's mandatory that you go on cardiopulmonary bypass, and with bilateral sequential lung transplant, it's not required. Now, in terms of complications, one of the challenges to doing the sequential lung transplant was that the main stem bronchi are quite small, and the blood supply to them is fragile. So if you just try to take the recipient's remaining airway and attach it to the donor lung, there's a good chance that you're going to develop scar tissue there. So it wasn't until they developed some what's called a telescoping technique, where they bring some tissue up that has some extra blood supply around it, that they were able to reduce the degree of fibrosis, or what we call stenosis, of the airway. In terms of allocation of organs, the bilateral lung transplant is more efficient because you could potentially get one lung from one donor and another lung from another donor. You're not using heart tissue as well. So this is what the incision typically looks like for a bilateral lung transplant. Many of you are familiar with the type of scar that you may see with a bypass surgery for heart surgery. It's usually a straight incision right over the breastbone or the sternum. But with lung transplant, the surgeons need to get exposure to both chest cavities. So they do this, what's called a thoracosternotomy incision. On the street, it's called a clamshell incision. If any of you have seen those cars that kind of, the roof folds up, it gives the surgeon the ability to access both chest cavities simultaneously. And it does leave a scar behind that's usually allows a woman, for instance, to wear a bikini top without having a scar visible. So that's one additional advantage. Okay. So this is actually an old slide. I had to put something in from the 1990s. Most of the data that's going to be in this talk is from just the last couple of years. But I put this in just to show you the challenges that we faced back in the early days of lung transplant for CF patients. This is actually an article that I wrote with Rob Kotloff from the University of Pennsylvania. And what we're showing in this slide is the number of patients listed, or number of patients on the transplant list versus the amount of donors available. So down here is the number of donors, and you can see it was kind of peaking and maybe falling off in the late 1990s. And part of that is because lung tissue is very difficult to preserve. And so as opposed to, for instance, a kidney or a heart, lung tissue tends to be damaged in a lot of situations where people would be potential donors. So that donor pool seemed pretty flat, whereas the number of people who are candidates for receiving lungs, and this is all comers, this is not just CF patients, but it was exploding. Next slide. Now, what was the fallout from that? Well, here again, we see the number of candidates for lung transplant going up, the number of lung transplants kind of staying flat, and what we were seeing in the late 1990s was that the number of people waiting for lungs was increasing, and the number dying while waiting for lungs was increasing. The way the lungs were allocated at that time was basically your blood type and how long you were waiting on the list. And so you had to wait in line, and that caused all sorts of problems, which we'll talk about in a few minutes, how as a community we've addressed that. So this brought up the notion of the transplant window. And this is a cartoon slide, but Dr. Kotloff and I put this together just as a paradigm, and there have been a lot of people who've done much more work gathering real data to fill this in. But the concept is that you want to transplant somebody when they're sick enough to benefit, but not so sick that they're not going to make it through the procedure or derive benefit. So one of the best indices that we have to look at for predicting survival in patients with any lung disease, but particularly for CF, is the FEV1. Does everybody know what the FEV1 is? That's a measure on the spirometry, your lung test when you come into the office, to look at how much air the patient can blow out in 1 second. And then we take that number and we put it on a table just like any sort of insurance table. You look at it and see what would their predicted number be and what is their actual number. And we come up with a percent on that. And it turns out that when you get below 30% of what's predicted for your age and your height, that's a problem. And long-term survival seems to be quite low. So we're looking at 2-year survival of 50% or less once you hit the 30% predicted line. And that's a number that's probably worth keeping in your head, because that's what doctors around the country are thinking about when they begin considering listing somebody for lung transplant. So 30% are predicted. What this graph is showing you is that with transplant, there are a percentage of patients who don't have long-term survival with transplant. But we find that when you have patients going into the transplant with a lung function less than 30% are predicted, they tend to do better with transplant than those who go into transplant with a much higher lung function. Now this is something, I only put this in here because some of you may have actually seen reference to this article in the lay press. It was an article in the New England Journal just last November from a group that's trying to develop models to best predict who would benefit from transplant. And they actually came up with a conclusion. It's too small for you to read in the back, but they said that our analysis suggests that prolongation of life by means of lung transplantation should not be expected in children with cystic fibrosis. This created quite a stir in the CF community. Certainly there's not this level of controversy in the adult population, but for pediatrics it raised a lot of questions as to whether lung transplant was going to give any sort of meaningful survival benefit. Problem with this study, the major criticism of this study, is that it's looking at data from back with my paper that we were talking about, where people were having really long waiting times on the list. Okay, so what was happening was people were worried that they were going to have to wait so long to get a transplant that they were jumping on the waiting list when they were still pretty healthy. So if you compare people on the waiting list who are quite healthy to those who actually got a transplant, sure, the people who are waiting a really long time look like they live longer because they're jumping on when they have 50% lung function or something like that. So they understood that limitation in this paper, and what they were calling for is now with the new listing system, we probably should be studying that going forward to really best figure out who benefits from lung transplant. Next slide. So what happened in 2005, I put a little arrow on here. In 2005, we changed the way we started listing people for lung transplant. It used to be, as I said, you get in line and wait. It doesn't matter how sick you are. If you're really sick, you may not make it until your turn has come. So there are a lot of people getting listed too early. And so a new listing program came up, and I'm going to go over this in a little bit more detail just so you understand it. But the basic idea is to try to get people who are sicker transplanted earlier, move them up on the list. And by doing that, we decreased the number of people on the waiting list. Okay, we actually were able to increase the number of transplants done. And shown down here is deaths on the waiting list. Those are actually dropping down somewhat. Next slide. This is shown again that people on the active waiting list were dropping down. People on the inactive waiting list were going up because we were able to triage, so to speak, how sick people were. Next slide. And here, look at the dramatic change in the waiting time. So here's the median time to waiting. And I remember when I first moved up here to Maine, when patients would ask me, well, how long is it going to take to get a transplant? I'd say, well, we might be looking at 2 to 3 years, so we better get started getting you listed because you got to get yourself in line, and that's a difficult conversation to have, especially when you have somebody who's working, to be thinking about getting on a transplant list when they're actually feeling reasonably okay. It's a difficult one. Now the waiting times are much shorter. Here again, we're seeing that the death rate of patients on the transplant list, it does seem like it was trending down before the change in the allocation system. And this is probably because people were figuring out how to jury-rig the system a little bit. What would happen would be somebody would be waiting, they're actually quite healthy, they get called up, your lungs are ready. They go, I'm too healthy to go for a lung, I feel too good, I'm not ready yet. Okay, we'll put you to the side and keep you building up your time. So some of this was probably from not transplanting people too early. That's why the death rate went down. So you can see here, this is showing you the patient survival on the ordinate, and this is over time by year. This is a little complicated, so I'm going to walk you through it. But each of these colors, that's called a cohort. So those are people from a particular group, and you might wonder, well, why is this cohort so short? Well, that's because we're looking at 10-year survival. So these people haven't had enough time to live for 10 years when they're 2005. So, we're looking at whether these graphs are going up this way. If we're doing better with our transplant technology, then the survival should be going up. This is 5-year survival, 3-year survival, 1-year survival, and 3-month survival. And you can see that there is some trend upward, but boy, we wish we could get some sort of magic bullet to reduce the post-transplant complications so that we see something like that. Okay. Now, as a patient, you say, how do we get started? And I put we in there because our team is part of that decision-making process with you. We're not telling you to go home and decide whether you're getting a lung transplant. We want to be part of that, but likewise, we're not telling you go and get a lung transplant. You're part of that conversation as well. So how do we get off the spot? Well, a lot of it has to do with your personality going into this. And everybody who's seen me talk at Maine Med, I think we rehash this. You have this slide. Who likes this slide too? This is the 4 basic personality types. It's another Far Side comment. And so you have on a table, you have a glass that's 50% full with water. And the first personality type says the glass is half full. The second personality type says glass is half empty. The third one says half full, no wait, half empty, no. What was the question? And then the fourth one, this one's, I have a lot of people like this. Hey, I ordered a cheeseburger. So I think my personal feeling is a lot of this whole process has to do with your attitude going into it. You know, the success that everybody is going to experience going through the transplant process is going to be how you are as you walk up to the table on this. And that's part of our job as a CF team, is to really poke and prod. That really takes every member of our CF team to kind of help all of us work through that process. So here's the personal checklist when you're thinking, am I sick enough? So I've given you a little bit of data. You should be, as patients get older, when they're going from pediatrics to adults, it's really important to take ownership of some of these numbers. That's what, you know, we care a lot about it, but nobody's going to care as much about your numbers as you are. So you should understand them. So the FEV1, what is your FEV1? What does that mean? How does that correlate with how you're feeling and how you're able to perform at work or at school? Is transplant something that I really want? That's a philosophical question, or maybe even a religious question. We have some people, for religious reasons, they would never get a transplant. That's okay. As long as you're comfortable with that and you understand it, there's a legitimate argument to say that that's not what you really want. Do you have a medical plan? So that means you have to be engaged in the process. Nobody is going to do a lung transplant to you. You're going to be part of that decision, and you have to be medically prepared. And if it's evident that you aren't medically prepared, then you're likely not going to get past the first step of the listing process. Do you have a financial plan? And this is something that we as a team have started, we're starting to explore that. We had a recent retreat with other members of the Northern New England Consortium, and we realized that's an area where maybe we're not doing as much as a center to provide education and resources to you. Not necessarily direct financial resources, but information about where you can get support. And I'm going to put a little pitch in at the end of my talk for you to touch base with somebody if you're thinking about lung transplant. We have a local superstar who's actually heavily recruited outside of our area to speak on how to develop a financial plan for lung transplant. Do I have a support system? So I'm not now talking just about financial support. I'm talking about, do you have friends and family who can help you through this very difficult situation? And that will be carefully scrutinized by the transplant center. As is the case with most challenges in life, it's difficult to go through it alone. And this is one of the biggest challenges. Is there's a reason I put that lunar module on that earlier slide. It's not just to talk about those bold surgeons, it's talking about you. When you get selected to be going for a transplant, it's like training to be an astronaut. You've got to show that you have the right stuff, and you've got to have the support to get through that. And so part of that process is learning about transplantation. And it's so disappointing to me to hear somebody initiate the process of transplantation but expect that it's all going to be fed to them. Because even if we do our best to provide the literature, if you're not nourishing yourself with that information, you're not going to meet your needs. We can't predict what information you really need to get through the process. So here are the general criteria. FEV1 less than 30% of predicted after using an inhaler is oftentimes what's used to kind of get through the first step. Now there are exceptions to that rule, but that's a good general number to have in your head. Those folks who have FEV1 over 30% of predicted, who may be having more frequent exacerbations, having to go into the hospital, progressive weight loss, and females, for some reason that we don't totally understand, are at higher risk for more rapid decline. So when we see a young woman with rapidly declining lung function, we may get them involved with the transplant process or evaluation process. Contraindications, and many of these things that I have listed here, they're becoming softer. When I mean contraindication, that means that you wouldn't be offered a transplant opportunity. Okay, but some of these things are a little bit softer, and they're individually evaluated. And what we were recently told by one of the transplant centers that we work closely with is that we shouldn't be making the decision that you're contraindicated. We should still provide the information to them and have them sit down with you and go over it. Okay, but just as examples, patients who have critical illness. So if you end up on a respirator in the hospital before being listed, that would be a contraindication. They would say you need to get off the ventilator before we would list you. If there are other types of infections like HIV or active hepatitis, those would be issues. I think what's clearer are those things that are under our control. So active or recent cigarette use is a real problem, and you will, as a candidate, you would be screened for nicotine metabolites. And issues about adherence to medical regimen, that's a softer one, but that's definitely scrutinized. So somebody who really can't keep all their therapies in order, that's going to be looked at, because after transplant, it's not as if therapy stopped. They're just different from what you're doing before transplant. So they need to be sure that the life-saving medications are taken on a regular basis. Okay, next.
Just nicotine use in the parents, too?
Well, and that can be an issue. It's maybe a little bit more theoretical than we think, but the way they screen for tobacco use is to do a urine test for nicotine metabolites. And those urine tests can come out positive from secondhand smoke exposure. And that can be a real issue. We've had a couple of patients where, because of their living situation, they were exposed to secondhand smoke. And some transplant centers will only give you one chance. Other ones, it goes before a big board, and they may give you 1 second chance. But it's not something where you can kind of rehab over several years with it. It has to be, you have to be clean in that respect. Now, this is too small to read, but I put this up just as an example. This is from the web. I actually, in my normal fashion, I got my talk together this morning. So I went on the web and got this. This is one of the transplant centers that we work with Brigham and Women's Hospital in Boston. And you can go on there and see how many transplants did they do. Okay, how many transplants were done in the region, how many were done at the center, what is their transplant rate, and what is their expected survival 1 year out. And on some of the tables you can even look at the 5-year survival. For the most part, the centers that are doing large numbers of organs, they're within a reasonable range, so that when you look at, they'll say statistical significance of difference. This says no significant difference. What that means is that there may be a 1 or 2 percentage point difference in 1 year survival, but it's not statistically significant. So I think there are other issues that come into play when picking a transplant center, like your support system. How can you get there? Are there going to be multiple visits? Are you going to go out to the Midwest because they're 3 percentage points higher, when it's going to be, travel costs are going to be exorbitant? So all those things have to figure in. Some patients may be curious about, well, what kinds of tests do I need to get when I'm going through the listing process? We're trying to get this streamlined. We still don't have everything ironed out with one of our partner transplant centers, but many of the centers now are trying to get this consolidated during one hospital stay, instead of having you go back and forth to get each piece here. But it does involve blood work, an electrocardiogram, which is an EKG. Heart catheterization is actually an important part of the listing process. That's where they put a catheter into, first, one of the big veins to measure the blood pressure in your lungs, because the pressure in the lungs makes a difference as to your priority status. And occasionally, if there's a question that there might be some blockages in the arteries around the heart, they might do a traditional left heart cath. But actually, left heart caths are much less common in CF patients than they are in patients, for instance, with emphysema. They want to get a CAT scan of the chest. Obviously, they want to see what the lung function is. And interestingly, there are other areas that may affect the post-transplant outcome, like sinus disease or acid reflux, that they want to at least have an idea of the scope of the problem before you go in for transplant. So then, how are lungs selected? This is a very complicated process, but believe it or not, for actually picking out the lungs, you just have to have a matching blood type, which is shown on this table. So this just kind of shows you the frequency of different blood types in the U.S. population. And it's a little bit of a balancing act. If you have a very uncommon blood type, then it might be harder to find a donor. On the other hand, there will be fewer people waiting in line with you, so so you may go up faster. Next slide. And then the other piece is the size. So it's blood type and size. There's not all this HLA matching and all that they do with kidneys, partly because of the delicacy of the organ, and you can't leave a lung out of a body long enough to do all this other testing. But we really do need to make sure that the lungs are not too big or too small for the recipient. So the size does matter. Now, I'm going to switch gears a little bit here and talk a bit about what happens after the transplant and mix that in with how do we then determine priority score. Okay, so we talked a little bit about what you need to get evaluated, right? Now we're going to talk a little bit about complications after transplant, and then finish up with so how does the transplant team come up with a score for putting you on the waiting list? So first off, thankfully the technical problems that we see after transplant are relatively uncommon, and when they do occur, they usually can deal with it. But this is just a pie chart showing you that graft failure and problems with the anastomosis, which is the connection between host and recipient, those are pretty uncommon. And if they occur, they can sometimes deal with that. Infections are a big piece of the pie right from the get-go, and they become a bigger issue as we go along. So the most common problems extending out from surgery involve rejection and infection. And I put this yin-yang on there because in one sense, infection and rejection are linked. We think that some bouts of rejection are actually triggered by infections. So the transplant teams, the good transplant teams, are really compulsive about seeing patients frequently and doing a lot of either blood tests, breathing tests, and sometimes bronchoscopy, where they'll look down and get samples from the lung to see that that lung tissue is healthy. Understanding that getting people off to a good start in that first year is critical for long-term survival of the transplanted organ. So what are the signs? There are two different types of rejection. One is acute rejection, which tends to be more dramatic, tends to happen a little bit earlier on after the transplant. And the signs of that are going to be fever, shortness of breath, and fatigue. Oftentimes there's sputum production, and there may be a change on the chest x-ray. So you might ask, boy, that sounds an awful lot like a pneumonia. And it oftentimes can look exactly like a pneumonia. And many times the transplant team will treat you as if you have both rejection and pneumonia. And they'll do a bronchoscopy. And fortunately, when they do biopsies in that situation, the diagnostic yield is pretty high. So by the end of the day, they should be able to tell you whether it's infection or rejection. The trickier one is when you get out beyond 6 months. And this is the big challenge in transplant medicine, is that almost universally, patients develop some degree of chronic rejection. And we're getting better and better at that, but these are the incremental changes that, like what Dr. Cairns was showing you, the 1996 to 1999 improvement in survival in CF, that shallow slope that's kind of frustrating. It's going in the right direction, but not good enough. And we're waiting for that big breakthrough, some new medicine that allows us to prevent this chronic rejection. Now, interestingly, just to talk about the last slide one bit more, we don't need to go back to it, but chronic rejection actually looks a lot like CF. So that can be frustrating. On the other hand, I think patients with CF who experience chronic rejection are mentally equipped sometimes to deal with what are the therapies. Improved airway clearance. Many of the emphysema patients, they've never even heard of airway clearance. So you're trying to teach somebody who's 50 years old to use an acapella or something like that. It's not part of their paradigm. So just to give you the heads up that is something that kind of folds into the picture. So when we make the calculation, where should you be on the list? We're actually taking that early data, which is how low is your lung function, how impaired are you, and then based on your overall picture, all this information that we get from the data, and what we know about post-lung transplant outcomes, what's that balance? And that's what's the lung allocation score. That's what was started in 2005. They balanced the transplant benefit, which is calculated, versus your wait list urgency, meaning how sick are you, and that's also calculated. And this is just an example, again, from the website. I won't belabor all the math, but it goes through a bunch of computations looking at your time on the waiting list, what they would predict your survival to be post-lung transplant, and they come up with a lung allocation score. And the higher the score, the higher you go up on the list. And you can move up and down based on how your physiology is. And that's one of the reasons why once you get assessed for lung transplant, they want to see you periodically, and they may say, you need to get an echocardiogram. And you say, but you already did an echocardiogram. Yeah, we want to see if it's changed, because we want to see if this score changes. So the value of the CF team, we're coming down the home stretch here. I just wanted to reassure all of you. I was relatively shocked recently when we were meeting with the transplant team in Boston, and some of our colleagues were talking to them, and they said, well, you know, whatever happened to such and such patient? And the transplant team said, well, they're doing well, or we've had this and that complication. And I thought, how does the primary team not know what's happening with their patient after they went for transplant? We're still seeing all of our patients. After their transplant, they still come to us, and we really do want to remain involved. We need to work out that choreography with the transplant center about who does what, you know, who manages the transplant meds, but we really do want to continue that input, and particularly on the adult side. I think that a lot of the adult pulmonologists at the transplant centers are not familiar with CF, so the GI issues, the diabetes issues, they're not as familiar with. So we really stay front and center. So this is a partially correct thing, that there's a handoff on the baton, but we kind of keep holding on to that baton a little bit, at our center at least. And this slide I just put in mainly just to have it in your handout if you're interested in checking out some of the transplant centers. Just like if you want to check out the CF center, you can get online and check out a transplant center. You just move the mouse over, you click on the state, and it'll bring up the transplant centers in that state, and you can look at how many they've done and what their outcomes are. So I encourage you to check these out. And then I think the last one is a pitch for New Lungs for Georgia. Scott, I don't know, Scott's right there. Scott's going to be willing to talk to you, but take advantage of our local resources. We're really proud that we have some patients who stepped up to the plate to not only help themselves, but to help those around them. And George, who's one of our adult CF patients, is more than happy to share the information that he's gained going through the transplant. He has not gotten a transplant yet, but he's in a very good position to financially support all of his needs around transplant. So we encourage you to either meet with him, give him a call, talk to Scott, check out online, make a donation. We encourage you to do all those things. Okay, with that, I'll open up to questions.
Do you want to talk a bit about our collaboration with the Brigham, the goals and the...
Yeah, so just in case the question wasn't picked up, Dr. Cairns asked about a collaboration that we have with the Brigham and Women's Hospital. This is not specifically to pitch one program over another program, because there may be specific reasons for somebody to go to an alternative program. But we've been really wanting to facilitate the transfer of information and improve the quality of the experience of going through the transplant listing process. We know that it's stressful. We know that it can be frustrating to go back and forth and have to make numerous appointments to get the testing done, to be waiting to hear an answer about whether you're actually activated or not activated on the list. And so we've had a number of phone discussions with the team at Brigham and Women's. Their surgeon has actually come up to visit our hospital and has seen one of our patients in the hospital to encourage him and get him activated on the list. And they seem to be committed to trying to develop some level of collaboration. So, for instance, the vision would be that maybe in the future they would actually come up here to do some of the evaluation rather than have you have to go all the way down there. I think that can only be a good thing. And even if it turns out that somebody decides for another reason to go to another transplant center, just like CF centers compare themselves to each other, transplant centers compare themselves to each other. So we have one place coming up to us, then another one will say, hey, how can we make it easier to make our process better? So we're going to try to leverage that offer. The Brigham, I think, is in a position where they really want to grow their program. So they're in the mood to reach out, do outreach to our program and the program at Dartmouth and Vermont, and we need to take advantage of that.
I have one question. Nationally, the number of CF patients, how many actually get listed or are interested in transplantation?
I'll have to pull that number up for you, but it is in the registry. We don't have internet access right here, I don't think, but I'm thinking that it's around 200, something like that nationally, but I may be off.
But the percentage is low, though, compared to numbers.
Yeah, there are about 20 to 30,000 patients nationally who have CF. This new listing process, I think, is a great thing for CF patients. I think it puts us at an advantage because CF can be a rather labile disease, and somebody can be kind of percolating along, and they really get into trouble at a certain point, and you don't want to have to be waiting 2 years at that point to get listed. So the fact that there's an acuity score is a good thing for us. Yes?
When we were in Florida and we were looking at this possibility, they told us we needed to be within an hour of a transplant hospital. Is that changed now? Because obviously we're not an hour from Boston.
Right.
Or Kansas or wherever else.
Yeah.
So has that changed, or?
It has changed somewhat. This is one of the variables that you need to look at for transplant centers. Some of the centers will actually fly you. They'll get you flown there. The Boston program doesn't do that, but we have a bigger time window. We're able to get people from the Portland area down there. Now, if somebody is up in Calais, that's not going to work from there. They'd have to relocate somewhere closer, but you don't have to be within an hour.
And does LifeFlight get involved in this at all, or would they get it, or the Angel? There's an Angel network I know in Florida that flies people for services like that.
They can. Yeah.
Okay.
Yeah, we've had people at Cleveland Clinic. They've been flown out. Yes.
Who do we partner with? This CF Center in Portland, like Boston, Brigham, or?
Well, we've used a number of different centers. I think most of our patients now are getting listed at Brigham, although we've had, when I'm looking at our adults, so we have 6 who've been transplanted, and 4 have been at Brigham and 2 have been at Cleveland Clinic. We have 2 people listed at Columbia in New York, which is a very successful program, and we've also had people evaluated at Pittsburgh, which is one of the biggest programs. And one of the things that can happen with a big program, they're able to absorb risk. So, the transplant centers are very attuned to these numbers too. They're out there for everybody to see, but they actually, their numbers go south they can actually lose their accreditation. So with a small program, they may be more reluctant to take a higher risk patient. So we didn't get into every nitty-gritty detail, but for instance, with certain types of lung infection, there may be some centers that would take a risk on certain varieties of cepacia, whereas another center wouldn't be able to take that risk. So we're partnering, I guess to answer your question.
Children's in Boston.
Yeah, Boston Children's, which is part of the,
Right.
and Mass General is another one where we.
Yeah.
Any other questions? I don't want to take up Tim's time. Great, well, thank you very much.